Hello everyone, I am Ms. Kajal Vaishya will be presenting on the topic comparison between retinal nerve fiber layer thickness, central corneal thickness and cup-disc ratio in ocular hypertensive and primary open-angle glaucoma eyes using optical coherence tomography. The aim of my study to quantitatively assess and compare the thickness of the retinal nerve fiber layer, central corneal thickness and cup-disc ratio in ocular hypertensive eyes with primary open-angle glaucoma eyes using the optical coherence tomography, that is Cirrus HD OCT spectral domain technology. Objectives: to compare RNFL thickness and cup-disc ratio in ocular hypertensive subjects and primary open-angle glaucoma subjects to determine correlation between central corneal thickness and intraocular pressure in these two groups, to determine RNFL thickness variation in all four quadrants, that is inferior, superior, nasal and temporal quadrants. Introduction. What is glaucoma? Glaucoma is not a single disease process but a group of disorders characterized by a progressive optic neuropathy resulting in a characteristic appearance of the optic disc and a specific pattern of the irreversible visual field defects that are associated frequently but not invariably with raised intraocular pressure. Primary open-angle glaucoma. POAG is the most common form of glaucoma, also known as chronic simple glaucoma of adult onset, is typically characterized by slowly progressive raised intraocular pressure greater than 21 mm of Hg recorded on at least few occasions, associated with open normal appearing anterior chamber angle, characteristic optic disc cupping and visual field loss. Ocular hypertension. The term ocular hypertension usually refers to any situation in which the pressure inside the eye, called intraocular pressure, is higher than normal. Eye pressure is measured in millimeters of mercury, mm of Hg. Normal eye pressure ranges from 10 to 21 mm of Hg. Ocular hypertension is an eye pressure of greater than 21 mm of Hg. Ocular hypertension is defined as IOP greater than 21 mm of Hg, no evidence of optic nerve damage, no visual field defects, open angles, no systemic or ocular cause for raised intraocular pressure. Optical coherence tomography. OCT is a diagnostic tool that can perform cross-sectional or tomographic images of biological tissues within less than 10 micron meter axial resolution using light waves. Types of OCT: time domain and spectral domain OCT. In this study, we use the spectral domain type of OCT, is also known as Fourier domain or spatially encoded frequency domain OCT machine work much as a spectrometer does, permitting results with just one exposure. This SD OCT image system provide image resolutions of 12 megapixels or more to within 5 microns. Spectral domain technology scans approximately 20,000 to 40,000 scans per second. This was my review of literature. Out of these two, which was specially done by Deepak Patel and Alfonso Anton, can correlate of this study. According to Deepak Patel et al., to correlate the findings of OCT evaluation of RNFL thickness in POAG, OHT and normal eyes, he shows that RNFL average thicknesses in all four quadrants in POAG patients were significantly decreased compared with OHT and the control groups. According to Alfonso Anton et al., explain usefulness of OCT parameters of the optic disc and the retinal nerve fiber layer to differentiate glaucomatous, ocular hypertensive and normal eyes. They concluded that mean RNFL thickness around the disc and superior and inferior RNFL thickness were significantly thinner in glaucomatous eyes than in OHT or normal eyes. Rim parameters were significantly smaller in glaucomatous eyes than in normal and OHT eyes. Cup-disc ratios were significantly greater in glaucomatous eyes than in OHT and normal eyes. Materials and methodology. Study design was prospective and cross-sectional study. Study period was July 2019 to Feb 2020. Study site was Advanced Eye Hospital and Institute, Sanpada, Navi Mumbai, India. The sample size was used in this study, that is 70 eyes. The study comprised of 35 OHT subjects and 35 POG subjects were included. The personal data of subjects, which comprised of age and sex. All subjects had a complete ophthalmologic examination including best corrected visual acuity assessment, IOP measure done by NCT, non-contact tonometer and GAT Goldman applanation tonometer, subjective refraction, slit lamp biomicroscopy, indirect ophthalmoscopy, gonioscopy, OCT optic disc and anterior segment perimetry done by Humphrey field analyzer, One eye of each subject was randomly selected for study. Subjects with OHT were required to fulfill the following criteria in both eyes: best corrected visual acuity greater than 6 by 12, 20 by 40 or more, IOP greater than 22 mm of Hg and less than 32 mm of Hg, open angles on gonioscopy and normal appearing optic disc. Inclusion criteria: age 40 to 80 years, best corrected visual acuity greater than 6 by 12, 20 by 40. Exclusion criteria were media opacity, severe medical or psychiatric condition, progressive retinal diseases, intraocular or refractive surgery. Results: according to table 1 represents comparison of average RNFL thickness between OHT and POAG groups. The average RNFL thickness in both the groups were 79.14 plus minus 12.52 and 68.46 plus minus 8.85 micrometer respectively, where p-value is less than 0.001, which was statistically highly significant. Table 2 represents comparison of RNFL thickness in inferior quadrant between OHT and POAG groups. In inferior quadrant, RNFL thickness among the two groups were 94.77 plus minus 28.33 and 75.14 plus minus 14.68 micrometer respectively, where p-value is less than 0.001, which shows statistically significant. According to table 3 represents comparison of RNFL thickness in superior quadrant between OHT and POAG groups, where 98.63 plus minus 25.58 and 85.54 plus minus 18.77 micrometer respectively, where p-value is equal to 0.0173, shows statistically significant. Table 4 represents comparison of RNFL thickness in nasal quadrant between OHT and POAG groups, where mean value is 62.26 plus minus 9.93 and 59.63 plus minus 10.37 micrometer respectively, where p-value equal to 0.2826, shows statistically insignificant differences between the two groups were observed. Comparison of RNFL thickness in temporal quadrant between OHT and POAG groups, where 60.17 plus minus 22.38 and 54.23 plus minus 13.56 micrometer respectively, where p-value equal to 0.0627, shows statistically insignificant differences as shown in table 5. Comparison of central corneal thickness between both the groups, where p-value is 0.1196, are statistically insignificant differences were found. Comparison of cup disc ratio between OHT and POAG groups. The difference in cup disc ratio of the two groups is statistically significant, where p-value is less than 0.001. The mean plus minus SD cup disc ratio across subjects were 0.62 plus minus 0.16 in group A and 0.77 plus 0.07 in group B, as shown in table 7. Discussion: glaucoma is the leading cause of irreversible blindness and the second leading cause of all types of blindness worldwide after cataracts. In this study, the following factors in the two groups, that is OHT and POAG subjects, were recorded: IOP by NCT and AT, CCT, cup disc ratio, RNFL thickness in all four quadrants, and average RNFL thickness. Differences in RNFL thickness for each quadrant were assessed to determine the quadrants in which glaucomatous, that is POAG and OHT, differed. This study also reported that RNFL thickness in inferior quadrant, superior quadrant, and RNFL average thickness have the best performance to discriminate OHT eyes from glaucomatous, that is POAG eyes. RNFL measurement with HD-OCT could provide important information for detection of early stages of glaucoma, pre-perimetry glaucoma, as well as help in evaluating progression of glaucoma. Mayoral et al. Found that average RNFL thickness can be used as a parameter of distinction between normal eyes, ocular hypertension, and patients with glaucomatous alterations. They also support that RNFL thickness can be used to distinguish ocular hypertension patients from those with early glaucomatous changes. In our study, subjects with OHT had thinner central corneal thickness as compared to the subjects with POAG showed statistically insignificant difference. CCT is considered an important variable in glaucoma. POAG subjects, those with higher CCT, are expected to have initially present with higher untreated IOP, and this higher IOP may have influenced the clinical decision making between medication and surgery. OHTs also found that CCT is a risk factor for glaucoma and a strong predictor for progression from ocular hypertension to glaucoma. In our study, cup-disc ratio is higher in POAG subjects as compared to OHT subjects. Eyes with physiologically high cup-to-disc ratio should not be overdiagnosed and should not be considered to be glaucomatous, and eyes with increased intraocular pressure, small optic nerve heads, and average or low cup-to-disc ratio should not be underdiagnosed and regarded to be only ocular hypertensive. An inter-eye asymmetry in the cup-disc ratio of greater than 0.2 indicates glaucomatous optic nerve damage. According to Blue Mountain's eye study showed that ocular hypertensive eyes had significantly smaller discs than patients with primary open-angle glaucoma. Limitations: the sample size in each of the two groups were small and the participants were not age matched. In our study, several types of glaucoma were not included. Comparison between subtypes of glaucoma can provide more meaningful analysis in this regard. There is lack of follow-up with subjects. Glaucoma being a progressive condition, serial follow-up with multiple RNFL studies could have given a clearer picture about the degree of RNFL loss. In our study, the CCT was measured with OCT. Although it was better assessed by pachymetry, it can provide more meaningful analysis. Conclusion of this study: Serious SD OCT detected significant quantitative differences in RNFL thickness between POAG and OHT subjects. The mean RNFL thickness in all four quadrants in POAG subjects were significantly decreased compared with OHT subjects. RNFL thickness in superior p-value is 0.0173, inferior p-value is less than 0.001. Quadrant shows significant results, while nasal p-value is 0.2826 and temporal p-value is 0.0627. Quadrant show insignificant differences in these two groups. When we compare average RNFL thickness, it shows significant result where p-value is less than 0.001 in both groups. POG subject shows thicker CCT, but statistically insignificant difference were found while comparing both groups. P-value is 0.1196. OHT subjects have lesser cup-disc ratio than POG subjects and show extremely significant results where p-value is less than 0.001. These are the references. Thank you.